So I am going to essentially take you through the work that we've been doing over the past year through the developmental evaluation, basically just 6 OHTs. And I'm going to give you a quick overview of how we collected data, analysis, and then key results and some recommendations, both for OHTs as well as for the people at the system level, so policymakers and so on. So developmental evaluation is essentially an evaluative approach that uses data derived through embedded research to understand and support OHT development. Well, in this case, OHT development. And it has 2 aims. So first, it's, we were trying to understand, study, research how OHTs are developing. And secondly, we wanted that to be actionable, right? So it aimed to transform that research into action to support OHT development. So 6 OHTs were included in the developmental evaluation, and there were 3 main criteria that guided selection. The first being geography. So we wanted to represent different geographies in the province, and we included teams from rural, remote, and urban geographies. We were also looking for readiness to engage in the developmental evaluation, the DE. So we were looking to see if they had certain components in place. So, how they self-reported their team climate or readiness for change, for instance, through, first the results from the HSPN organizing for OHT survey that we did, and secondly, through a document analysis of the OHT applications themselves. And then secondly, we did also realize that participating in this work was not without effort, right, on the OHT's part. So they also had to be willing to work with us over, what ended up being a year. So we started data collection in the spring of 2021, and we finished a year later. We used multiple approaches to data collection. So we primarily conducted observations at meetings at different levels of the OHT. So this might include steering committee meetings, working group meetings, and so on. And there were 5 of us doing this. So there was an embedded researcher in, each of the 6 OHTs. And this was, so it was Walter, Ruth, Ilana, Kaylee, and I. And we were all sort of assigned to a specific team. We also conducted a set of interviews, about 5 to 7 interviews with each OHT, and we invited a range of OHT members to participate in a journaling activity, a reflective activity as well that they did sort of over the course of the year. We also did some document analysis and surveys, so for instance, on provider and patient experience and so on. So often in qualitative work, you go in with a question that you're trying to answer, but you typically don't go in blindly, right? You're usually looking at the literature because you're trying to figure out what theories or constructs are already out there that can sort of help you think through your through your findings and that you can sort of build on. So the CCIC framework, that's the context and capabilities for integrated care, that was one of those frameworks that provided a very loose guide for data collection in the early days. And then because the ministry had drawn up a list of building blocks to guide OHT development to its maturity, we looked at those constructs too, to see if they could maybe, make what we were finding actionable for OHTs. But, whilst these frameworks shaped our thinking, they were really not used as checkboxes. So we were most interested in seeing what our observations on the ground would bring up that was new, so an inductive approach to research, right? Because that really is kind of the point of qualitative work, so not to fit things into pre-existing boxes, but rather to see what new boxes might emerge, or, what lies in between the boxes. So I'm really just going to walk you through some of the highlights that emerged from our on-the-ground observations and interactions over time with these 6 OHTs. So 3 of our key findings, the first being that OHTs were evolving at different paces, and each was at a different stage of progress in relation to key areas of development. Secondly, despite differences in evolutionary trajectory, there were shared contexts, structures, and cultures that both forwarded and frustrated progress across OHTs. And a third, there were overlaps, but also key qualitative differences between what OHTs were supposed to be doing, and the supposed is sort of enshrined in the ministry's 8 building blocks for OHT maturity. So there were sort of differences between that and what we were actually observing them doing on the ground, right? So what was important to them on the ground. So first, the idea that OHTs were evolving at different paces, and this should not be particularly surprising because obviously each team is somewhat unique, right? They have different histories, different levels of pre-existing collaboration. They are located in very different geographies, each with their unique benefits and challenges. They had different attributable population sizes and so on. And some met with unexpected structural challenges, such as being asked, for instance, to sort of amalgamate with a neighboring geography, right? Merge with a smaller neighbor that perhaps had been expecting to be their own independent OHT. And another thing that contributed to the developmental journeys being different was perhaps the lack of clearly laid out shared policy level guidance, but more about that in a bit. And yet, despite these differences in evolutionary trajectories, there was a good deal of overlap in OHT parts across the nine key areas rather that sort of emerged through our observation of OHTs on the ground. So these were the key areas of development that we observed for vision development being a key theme really that was actually missing in the ministry's building blocks, but all 6 OHTs spent a good amount of time essentially figuring out, what they were supposed to be about, where they were going. So all focused on, patient and partner engagement, collaboration, how to develop person-centered care, the role equity would play and so on, but some emphasize some of these things more than others. And establishing governance. So one OHT was able to incorporate as a nonprofit corporation and set up a formal governance structure, but others were really engaged with relationship building and figuring out how to make decisions collaboratively. So essentially the work that had to be done before governance structures could be formalized. Third, strategic planning. So this was the work that went into actually materializing teams of visions, right? So how to translate your vision into something tangible that would make a difference to patients. And OHTs did this by drawing up sort of schemas of high-level goals and drivers, outlining strategic plans, pillars. But discussing this, writing this out, sharing it was itself an important extension of the vision development work, and it provided a roadmap for the next area, that being designing integrated models, right? So a few teams took this slowly. They really wanted to gather data, conduct research on the ground, really figure out what, where needs lay before designing new pathways. But others went ahead full steam, and they started piloting new initiatives almost from the get-go. And interestingly, these weren't necessarily the old teams, right? The teams with the long-established histories and so on. But sometimes just the doing itself sometimes helped people get to know each other and build relationships. So it works sometimes. Okay, the next 3 areas make an appearance in all integrated care initiatives, and these are, well, creating digital health solutions. So this involved working on sharing patient information, supporting virtual care, then engaging primary care. So primary care or physician councils were set up in areas where there was already a collaboration in the sector, and where there was not, just simply figuring out how to go about setting this up itself brought people together, right? Then partnering with patients and families. So all OHTs were moving or had moved towards a standalone patient, family and caregiver council with representatives, who would then sit at leadership tables and working groups. So the last 2, funding and incentive structures and performance measurement, quality improvement and continuous learning, we actually had the least amount of data on. And this was because there was a good deal of variation on whether teams even prioritize this stuff in the first place at the get-go, because many were just getting started and these weren't on the top of the priority list. As with funding, it mostly emerged as a system-level challenge, and I'll get to that. So there was some variation across OHTs in terms of which of these areas got prioritized, which took a backseat. But despite this, there were certain things that helped or hindered progress across all these areas. Some of the things that helped were, high levels of trust, shared values and priorities, making time for sense-making, learning, alignment between organizational and OHT priorities, engaging partners, community groups, providers, and subsectors, and clearly delineated and distributed leadership and accountability structures, strong communication around key priorities, a prior history of working together, and human and financial resources, a dedicated staff team being particularly important here. So progress was frustrated essentially, by the absence of these things, gaps in these things. But in addition to that, it was also frustrated by these three things you see listed below, which is, unengaged stakeholders. And by this, I do not just mean, unenthused stakeholders necessarily, but also just stakeholders, partners who should have been engaged perhaps, but for various reasons, whether because of, policy or funding related challenges, maybe historical issues, and they were not. So for example, this might take the form of not being able to fully engage home and community care or Indigenous partners. So over the course of the past year, we observed OHTs navigating, striking a balance between planning work and implementing work, right? So between thinking and doing. So some OHTs, for instance, prioritize developing robust macro level cross OHT structures to support work. So work such as governance, right? Others worked on at the organizational levels, building robust partnerships, improving collaboration, and still others dove right into piloting small-scale initiatives that targeted subsets of their priority populations. The most important thing, however, and this is something that was not easy for all OHTs, especially those that were focused on getting things done as fast as possible, was just pausing, taking a breath, and perhaps resetting. So we're calling this sense making here, but it's really just understanding how and why people interpret the world and give meaning to it in the ways that they do. So taking time to understand the different lenses that people from other sectors might bring to bear on an issue, ensuring that how you understand things really is in fact shared, and if not, acknowledging those differences and trying to bridge them where possible. So it might become clear that not all partners have a clear understanding of how initiatives were aligned with broader OHT priorities. So just slowing down to take stock, to learn, iterate, engaging, challenging conversations really helped. And sense-making and learning processes might include conducting evidence reviews, engaging with learning supports, bringing in external consultants, and so on. And it was really this work of sense-making that resulted in the development of new ways of thinking and working, right? So it was a foundational work needed to move from discrete organizations to an integrated network. So moving on to a challenge that was shared by all OHTs, and this was the need for clear and coherent policy and system level direction. So at the outset, policies and system level resources that were not overtly prescriptive kind of allowed OHTs to set out priorities that were locally relevant. It was seen as sort of a good thing. However, it quickly became clear that OHTs were also navigating policy and system level sort of gaps and uncertainties. So they had to work around a system that did not allow for sharing of patient data across all sectors, a system that did not allow them to fully engage sectors such as home and community care. There were unclear reporting structures, conflicting information from the ministry, OH, regional OHs. There were CQIP indicators that did not necessarily reflect what was important to OHTs themselves. One of the biggest issues that emerged concerned funding, the lack of it when it was absent, and the way it was done when it was present. So for example, the onslaught of funding calls, right? So these often resulted in a lot of work for OHTs, because they now needed to do the work of figuring out how to align them with their existing initiatives, or vice versa if they wanted to be really creative. And on top of that, there were typically small pockets of short-term funding. And in fact, the short-term nature of funding was a huge issue. So a robust staff team, for example, was terribly important to OHT success. And not knowing if staff members could continue for another year because of the lack of OHT funding renewals being in place kind of hit teams hard. And they were essentially being asked to engage in long-term work, population health management, essentially with short-term resources, and sometimes resources that did not always align with where OHTs saw themselves heading. So lastly, reimagining the building blocks. So just finally, the building blocks as a refresher, these are the original 8 OHT readiness criteria that were outlined by the ministry back in 2019 in the original guidance document. And these set out what OHTs should focus on as they progress from year 1 to maturity. And it was described as a list of mutually exclusive and collectively exhaustive domains where OHTs would need to make strategic choices. So while all these domains were certainly relevant to OHT development, having observed OHTs on the ground, we found discrepancies between how OHTs were meant to develop and how they actually did. And we found that the building block domains are not necessarily mutually exclusive. In fact, they kind of intersect and inform one another, right? So developing performance measurement and quality improvement plans, for instance, might first require work on strategic planning and model design. So as currently set out, the building blocks also categorically combine key areas of development. So building block 6, which is leadership, accountability, and governance, for instance. This is such a huge area that combines everything from governance, strategic planning, to primary care engagement in a single bucket. So it sort of risks glossing over the very different resources and activities that are needed for each one. And also acknowledging that certain aspects of OHT development can only begin once progress in other foundational areas has been made, may be reassuring to OHTs that are worried about not making inroads in some of these things. So all this to say that while there is certainly overlaps between the building blocks and what we saw on the ground, paying attention to the discrepancies is useful because they underscore the differences between the expectations of policymakers and the preoccupations of OHTs on the ground. Okay, so we're moving on to recommendations. We're starting with OHTs. So I'm just going to read these off. So OHTs needed to invest upfront work into developing a broad vision that is meaningful to participants. It is vital for OHTs to make time for sense making and reflection. Priorities should be locally relevant and meaningful, acknowledging provincial priorities. Communication with the OHT is essential, particularly in the initial stages. Attention to relationship building and trust should be an ongoing effort. So what all these suggestions have in common, perhaps, is the importance of a shared framework across all OHT members. So a collaboratively developed vision that is translated into locally meaningful and provincially aligned priorities that are then well communicated and revisited continuously, just to ensure that everyone is still on board and understands things the same way. Okay, these are recommendations for policymakers. Continuously reaffirm and communicate the vision for all OHTs, commit to long-term guidance and funding, improve communication between policymakers and OHT supports, revisit the building block framework to better reflect the different components of integration readiness and OHT's experience on the ground. So in essence, it's a recommendation that policymakers develop, communicate, and reiterate a singular vision to OHTs that shows the way, whilst also acknowledging the importance of allowing OHTs to interpret that vision in locally meaningful ways, while simultaneously working towards eliminating the systemic handicaps and committing, most importantly, it seems, to long-term funding.